So a very good evening to everyone. I am Suruchi Aggarwal and I work as a senior scientist oncology at Genome Labs. So we are basically a diagnostic lab for molecular testing in this part of the world, catering to mostly Southeast Asia. And in today's session, I have I would talk about immunotherapy biomarkers in non-small cell lung cancer. And Dr. Syed is my colleague, and he will be talking in detail about PDL1. However, I will set the stage with introduction to immunotherapy biomarkers and discuss about TMB and MSI in detail. So just, starting off with like Globocan 2020 data, we have a high burden of lung cancer, which is almost 5.5% of all cancers, and out of which non-small cell lung cancer accounts for approximately 85% of all lung cancer cases. And if we see in recent years, we have shifted the treatment paradigm from chemotherapy, that is cytotoxic therapies, to personalized targeted therapies that will act upon specific genomic alterations. And prognosis of non-small cell lung cancer, as we know, is extremely poor with very low 5-year overall survival rate. However, with immunotherapy, it has been seen that 5-year survival rate of patients with non-small cell lung cancer has increased significantly. Immunotherapy, no doubt, has revolutionized cancer therapy in recent years. And immune checkpoint inhibitors, they have demonstrated unprecedented rates of durable responses in some of the most difficult to treat cancers. However, there are a group of patients where there is no response or there are serious side effects. So in order to select a group of patients that will be benefited from immunotherapy, we have to identify certain biomarkers with high sensitivity and specificity. So this is like we have to tailor immunotherapy treatment regimens and several biomarkers, they are being explored for this reason. That could be like some serum proteins, tumor-specific receptor expression patterns. There could be factors in tumor microenvironment. There could be circulating immune or tumor cells. There could be some host genomic factors or common biomarkers that we look at in for immunotherapy, like PDL1, TMB, and MSI. So biomarkers, basically, they remain a missing link as there are limited large prospective trials to establish validation on their use and assay development and interpretation. So we have to look more into that part to establish biomarkers to actually identify a group of patients that will be inhibited through immunotherapies. So we have a candidate biomarkers which can be, tested for immunotherapy response prediction. So this particular slide shows holistic approach that can be used, to predict immunotherapy response. For example, there is a lung cancer patient. We will identify tumor mutations that can be identified in tumor tissue or circulating tumor DNA. With NGS sequencing, we can also identify tumor mutation burden. PDL1 we can identify through IHC, and there are other biomarkers like immune microenvironment, T-cell inflamed, gene expression profiling for some cytokine-related genes, and cancer driver mutations or co-mutations that are occurring along with these immune checkpoint biomarkers. So holistically, we can determine immunotherapy response. Common immunotherapy biomarkers in non-small cell lung cancer is like PDL1, which is most extensively studied, and targeted FDA-approved targeted therapies are available. It is defined as a percentage of tumor cell expressing the PDL1 protein, and it is determined based on different scorings, which will be discussed by Dr. Syed in detail. TMB is a tumor mutational burden, number of mutations per MB of DNA or genome, and it is predictive biomarker for clinical benefit from immune checkpoint inhibitors. And TMB greater than 10 mutation per MB of genome is considered as intermediate or high. More than 15 is usually considered as high. And this is mismatch repair deficiency, defect in mismatch repair genes, or we call it as microsatellite instability. And this is a actually solid tumor agnostic marker across different solid metastatic cancers. And this timeline figure provides like what drugs or targeted therapies were approved in in which year. So as you can see, for non-small cell lung cancer, PD-L1 IHC 22C3, for this particular clone, pembrolizumab was approved in 2015. For PD-L1 SP142, for atezolizumab approved for non-small cell lung cancer in 2018. For ipilimumab, IHC 28, non-small cell lung cancer in 2020, and TMB and MSI we have collectively for all solid tumors approved. Coming on to TMB, so tumor mutation burden, as I said, is a total number of somatic mutations that occur per MB of genome, and it correlates with high neoantigen presentation or levels that will activate anti-tumor immune response. So as you can see, it is low, so neoantigens are not there, but high neoantigens are there. So they are in non-small cell lung cancer, TMB levels are typically high in smokers or in former smokers, and low TMB score is mainly found in never smokers. TMB levels, they also vary with driver mutation profiles. For example, if it is a KRAS, MET, or BRAF mutated non-small cell lung cancer, it will usually have TMB high profiles as compared to EGFR, ALK, or ROS1 driven cancer. Even in EGFR driven cancer, if it is exon 19 del mutated, they may have low TMB as compared to L858R or 719 mutated tumors. However, TMB is a dynamic biomarker, and it is always influenced by the previous therapies, chemotherapy or radiotherapy, which actually impacts tumor microenvironment. So it basically depends on the microenvironment of the tumor based on the stage of the patient or former therapies that has been given to the patient. So TMB has to be carefully correlated with the therapy indications. How to test TMB? So as we discussed, that TMB is acquired somatic mutations, number of somatic mutations that occur in per MB of genome. So total coding region that is covered in our assay is 1.5 greater than 1.5 MB. There are different methods to determine tumor mutation burden. It could be whole exome sequencing, but we have FDA approved tests like Foundation 1, MSK Impact. So as you can see, Foundation 1 covers 1.1 MB of the panel that Foundation 1 uses. It covers 1.1 MB length of genome, and MSK Impact uses approximately 1.5 MB. And these are the different types of mutations across the genome that is being captured by each assay. So WES captures non-synonymous coding mutations as well as oncogenic drivers. And synonymous and non-synonymous mutations are captured by Foundation 1, and non-synonymous and oncogenic drivers again by MSK Impact. So this slide is just to show you that what is available as a benchmark and what we are using at MedGenome. So we are covering like 485 genes that spans around 1.65 MB of genome, and next generation sequencing is performed at greater than 250x depth. TMB and clinically relevant actionable variants are reported in a single assay, and results are interpreted as per international guidelines. Sample type is... Yes. Sorry. Okay. So sample type is FFP tissue block with greater than 10% tumor content. If we talk about microsatellite instability or defects in MMR genes, they are short, randomly repeated sequences of 1 to 6 nucleotide long, and they can be located anywhere in the genome, like in gene or intergenic regions, mostly present in introns or promoter regions. So there could be like repetition of those sequences or gain of those repeat sequences. So for example, and it will lead to replication errors. So this particular slide shows PCR fragment analysis. So this is a normal tissue or a normal blood profile. So there's a single peak, but if here you see there are two different types of lengths of microsatellite we will get. So we are getting two different peaks. So instability has happened here. so in the tumor. So that's how PCR fragment analysis is done to determine MSI. So cancers that harbor mismatch repair defects, they are hypermutated and they accumulate mutations in microsatellites, and they are prone to mismatch errors. So it can be tested using immunohistochemistry for DMMR for expression of particular genes like MSH6, BMS2, MLH1, MLH2. It can be also done by polymerase chain reaction, that is PCR-based method, and it can also be done by next generation sequencing approaches these days. MSI is usually a hallmark of Lynch syndrome, and it is a predictive biomarker for immunotherapy in various solid tumors. So we have all the 3 types of tests, that is IHC, PCR fragment analysis, and 27 markers by NGS. And similarly, sample requirement is FFP tissue block. Like we discussed that holistic testing is important to determine the predictive immunotherapy response or targeted therapy response. So this is a comprehensive solution that we have. It covers complete coding regions of 500 plus genes, and like all base substitutions, fusions, amplifications are covered. And TMB and MSI status can also be determined in this assay, and PDL1 expression by IHC is optional to be added to this assay, and sample type is similar. So this slide I have taken from ESMO guidelines, and it shows basically the relationship among different types of immunotherapy biomarkers. So I just thought to show this slide
because in non-small cell lung cancer, you can see that MSI is just 1.1% overlapping in the samples. However, PDL1 and TMB biomarkers, immunotherapy biomarkers, they are overlapping in almost 12% of patients. So the testing of biomarkers completely, like all the biomarkers, is important to determine the response to immunotherapy rather than just going ahead with one biomarker. This slide also again shows that in non-small cell lung cancer, MSI prevalence is very low. And this is the slide which shows that in non-small cell lung cancer, there are various driver mutations, and immunotherapy response could be different in the lung cancer, which have different drivers. For example, in ELK rearranged cancers, response to IO can be up 0 to 20%. BRAF mutation, it could be high because they are TMB high, as we discussed, 25 to 33%. Again, in KRAS, it is 57%. Again, KRAS mutated tumors are TMB high. So this is a nice review which showed like the response rate to IO could be different in differently mutated cancers. And this last slide I had put to show like what are the biomarker strategies, because if you see this is a PDL1 as well as TMB high group. So here the quality of new antigens is good, and the target other immune checkpoint inhibitors, and it overcomes T cell exhaustion. So we need to check again to reiterate the point that both the biomarkers or all immunotherapy biomarkers needs to be tested for better immunotherapy response prediction. So over to Dr. Syed to discuss PDL1 testing in detail.